Good evening, dear friends. I'm glad to welcome you to our next webinar. I'm Dr. Elena Lapina. I'm co-founder of Olga Fertility Clinic. First of all, I would like to thank you for the warm feedback about our previous webinars. It is so important to feel closely connected to you despite the physical distance between us. We will start with the story of our dear patient Ingvild and her difficult path to the birth of her daughter Jenny.
Hi everyone, I am Ingvild from Oslo, Norway. After nearly 20 IVF attempts in Norway and Denmark, I was fortunate enough that my gynecologist in Oslo told me, "You really need some help." The only one I trust to recommend to you is Dr. Olga. She has integrity, knowledge, and if anyone can help you, it's her. After 12 years of wandering the halls of different clinics, sometimes happy, sometimes depressed, lonely, sad, spending money, sacrificing time with friends and family, and even work opportunities, I was skeptical, but I trusted my gynecologist enough, so I decided to make a short trip to St. Petersburg to check out if this was another money-making clinic that not really cared about their patients, or if it had some substance. No treatment, just checking it out. And I was reassured. I must admit I also had some worries about traveling to Eastern Europe and Russia, but that part was fortunately changed during my first visit. St. Petersburg is one of the most beautiful European cities I have seen, a city to fall in love with during winter, with eyes on all the canals and rivers, Christmas lights far better than New York or London, and during the summer, festivals, people, joy. It's more beautiful than Venice, and I fell in love. So I decided to go back and give it a shot, although I had nearly given up hope. During my consultations with Olga and her doctors, and their evaluation of my medical history, it became clear that something was not right. I had had nearly 20 failed IVF attempts with only 2-3 implementations, and they all ended up in early miscarriages. Olga recommended me to do a hysteroscopy at her clinic. A peeling of the lining in my uterus, she explained, much like peeling your face to avoid wrinkles. You need a very skilled surgeon to perform this, but it increases the chances of implementation. I checked with some of my medical network that I had acquired during my 12 years, and they confirmed that most doctors take too much lining during such a procedure, as they don't have knowledge of how to prepare the lining for IVF. It's an art like so much else. While doing this, Dr. Elena would also investigate my uterus to see if she found something else. Indeed, she did. Elena told me I had adenomyosis. Excuse me? What? I could not even pronounce it. So I got a piece of paper, wrote it down 3-4 times, still without being able to pronounce it. Later, I got all the paperwork, excellently translated from the clinic, and was told that we needed to change strategy if I was to have any chance at all. Adenomyosis is a common female medical challenge, similar to endometriosis, but much less known. That's probably why you haven't heard about it. And as many female medical challenges, little researched. Bottom line, it makes the uterus an unfriendly environment for a fertilized egg. It makes it challenging for the embryo to implement and challenging for the placenta to grow and feed the baby. And as the fetus grows, it can hinder the uterus muscles to expand properly and thus create contractions and miscarriages during pregnancy. Well, I went back to Norway, surprised by this news, a little skeptical, and determined to get a second opinion back home. I Googled my way and found a doctor at Oslo's most prestigious hospital that had done her doctorate on adenomyosis and got an appointment. The Russians says that I have adenomyosis. I still have my little paper note in my hand, having trouble pronouncing it. But I have been in and out of fertility clinics for 12 years, and no one has ever mentioned this. Can this possibly be true? The doctor smiled and said, "Well, let's see what we find." One ultrasound later, she confirmed Dr. Elena's diagnosis. That's when I nearly lost it. "But how can this be?" I said. "I have spent all my mental, physical, and financial resources trying to get pregnant for the past 12 years, and no one has ever mentioned this? Well, she said, probably because only 2 to 3 doctors in Norway will have the knowledge to diagnose this. So I went home and cried into my pillow for a few hours, crying over the wasted years I had spent, wondering if I should dare to get my hopes up again, and even more, dare to get into another exhausting treatment process at my age. I was approaching 48. And yes, I did. And yes, it was challenging with more medication, more plans, more uncertainty. But never have I felt so taken care of. So reassured, so seen by outstanding medical expertise that treated me individually the way I needed. And almost 2 years ago, I gave birth to Jenny, the most precious little miracle I have met. She smiles in the morning when she opens her eyes. She tumbles around outside as it now is getting towards spring. And if I knew what I know today, I would take on those 12 years again any time. But if I had found Dr. Olga and her team earlier, my endless desert walk through for other fertility clinics would have been unnecessary. Nearly 50 years of age, advanced adenomyosis, 12 years of desert walking without success, I really was one of those patients clinics don't want, as more often they cannot help, and it messes up their success statistics. But Olga and Elena took me on, and here I am 3 years later with the most beautiful daughter you can imagine, and with more bubbly happiness than I ever thought possible. If there was hope for me, they most likely can help you. And you can rest assured that you have found the clinic with the best qualified expertise you can look for. They will do whatever is possible within their power to help you.
This is not the first time I've been listening to this story, but my heart still aches every time I do. After all, I know how much Ingvild had to go through. However, despite all the difficulties, she always wears a smile on her face. Ingvild and Jenny, please be happy. So, today we talk about pregnancy loss. But our main focus will be on the maternal causes of pregnancy loss. At our previous webinar, we told you how important the embryo is, and indeed it is. But here we are. We got a wonderful, strong, competent embryo. How now our task is to prepare a gentle, supporting environment so that it can develop feeling like this baby in a tender flower bud. So, the natural conception in human is such that most pregnancy losses occur already at the pre-implantation stage. It doesn't matter if this conception is natural or through IVF. Many losses happen before the 12th week, but once the pregnancy has reached 12 weeks, then it's most likely that it will stay and end with the birth of baby. Thus, pregnancy losses can be divided into pre-implantation and post-implantation losses. In the case of natural conception, we do not even know that the embryo has formed and could not attach. In the case of IVF, a negative test for HCG makes us ourselves. What happened? Did something go wrong? If an embryo managed to attach and then its development stops at a very early stage, then we will see a positive HCG result. But with ultrasound, we will not find the gestation sac. This is called a biochemical pregnancy. When pregnancy loss happens after it was confirmed with an ultrasound, it may be a miscarriage or a stop in embryo development, which is called a missed abortion. And again, in 75% of cases, it is the embryo that is responsible for the outcomes of fertility treatment and pregnancy itself. Please take a look on this slide. You see that the frequency of miscarriage increases with the woman's age. Why does that happen? Of course, with age, various diseases such as hypertension, diabetes, and others become more common, but not so much as to be a reason for such significant difference. Please look at the age 30. The pregnancy loss rate around 10%. And then at the age of 40, 50 of pregnancies and of miscarriages. When doing genetic studies of embryos and miscarriage products, we see similar results. With age, the proportion of embryos with the wrong chromosome set increases. Here and there. Such embryos may stop developing even before implantation or develop further, but later lead to miscarriage. Dr. Olga Zaitsev spoke in detail about why and how a mother's age affects the stage of the embryo, and I will not stop there. Now we have got this wonderful, strong embryo. Let's see what maternal factors can affect conception and gestation. On the one hand, we can divide the pregnancy, the problem with pregnancy on the different reasons. There are so-called anatomical factors, myoma, endometrial polyp, and so on, hormonal factors, immune factors, and the increased tendency of blood to form blood clots. We divided the categories, but often these factors combine and make each other negative effect stronger. And on the other hand, a woman's reproductive system is very finely tuned and adjusted. The subtle mechanisms of hormonal and immune balance are closely intertwined and interconnected. And of course, first, I would like to show you this beauty. In fact, preparation for pregnancy begins during the menstrual cycle. When the female sex hormones estradiol and progesterone are optimizing the uterine environment for conception and implantation. The growing follicle, which contain in oocytes, produce estrogen. The concentration of estrogen reaches the maximum at the time of ovulation. Under the influence of estrogen, the thickness of the endometrium increases. Around of the middle of the cycle, the follicles breaks, the egg enters the fallopian tube, and the corpus of luteum forms in the place of the follicle. This is when the progesterone production starts. Under the influence of progesterone, the endometrium changes in the amazing way. It becomes ready to accept the embryo and allows the further development of the pregnancy. It might seem like just a hormonal cycle, but let us take a look in more detail. This figure shows the key immunological mechanism that allows the endometrium to accept an embryo. These immune mechanisms are under the absolute control of estradiol and progesterone. Estradiol and progesterone selectively activate or suppress immunocompetent factors. Moreover, in different parts of the reproductive system, they act in completely different ways. A little later, chorionic gonadotropin, which is produced by the embryo from the very first moments of implantation, comes into action. The leading role of hormones extend not only to the endometrium as a point of contact between the mother and embryo, but also to the entire woman's body. Here, in just one example of how interconnected everything is in our bodies, the intestines, as the largest immune organ, and the composition of the intestinal flora seemingly have nothing to do with sex hormones and pregnancy loss problems. However, it turns out that estradiol can affect the composition of gut microbes directly or indirectly, forming the immune environment of the intestinal mucosa. Estradiol activates the pro-inflammatory cytokines. A pro-inflammatory immune environment disrupts intestinal permeability. To put it simply, it lets intestinal germs to leak through into the mucous membrane, where they can cause pro-inflammatory responses. If progesterone does not balance out the excessive influence of estrogens, then it can lead to changes in systemic immune responses and affect the immune acceptance of the embryo. And now our circle is complete. Implantation and development of embryo are possible with a special immune state. The balance between hospitability and aggressiveness of the immune system towards the embryo is regulated by sex hormones, among which a huge role belongs to progesterone. A decrease in progesterone concentration is a trigger for the body to start the embryo rejection reaction. Conditions such as hypo or hyperthyroidism, high prolactin levels, polycystic ovarian syndrome, obesity, and other conditions that cause to disbalance of the menstrual cycle inevitably lead to increased chances of miscarriage and implantation problems. And on the other hand, a woman's reproductive system is very finely tuned and adjusted. The subtle mechanisms of hormonal and immune balance are closely intertwined, interconnected, and of course, first, we can discuss and divide on different diseases. And we can start talking about thrombophilia and pregnancy loss. Thrombophilia means that blood has an increased tendency to form clots. This state must be subtle and because of that even more dangerous. Most people with thrombophilia have no symptoms or any health problems. Symptoms only occur if thrombophilia causes and blood clots to form. Women with thrombophilia have a high risk of losing pregnancy. Even in the early stage, they are also at high risk of late pregnancy complications, such as eclampsia, fetal growth retardation, or placenta abruption. Thrombophilia can be either hereditary and acquired. The most common causes of hereditary thrombophilia are factor V latent mutation, factor II or thrombin gene mutation. In these cases, clots in veins form the most often. In case when antiphospholipid syndrome develops, high concentration of homocysteine will make both veins and arteries suffer. How is that dangerous for pregnancy? Let's look at how the placenta works. In the placenta, The vessels of the embryo and mother are connected but not merged. This is how oxygen and nutrients are delivered from the mother to the embryo. Blood rich with oxygen flows through the arteries on the mother. Blood without oxygen flows through the veins. And what happens if blood clots block small arteries? In this case, the placenta doesn't function as well as it usually does, and this leads to complications or even to a stop of embryo development. If a blood clots block a vein, blood continues to flow, but outflow is complicated. In this case, the space between the maternal and fetal parts of the placenta fills with blood and exfoliates. We see a paradox. On the one hand, thrombosis, and on the other hand, bleeding. Therefore, it is very important to continue using low molecular weight heparins in case of bleeding during pregnancy in this situation. In the case of thrombophilia, we do not have a large variety of medication what we can use. However, their proper use and combination, as well as the careful monitoring of the condition of pregnant women, help us to improve pregnancy outcomes and reduce the number of thrombophilia complications. So, the next discussion topic is the immunological factors of pregnancy loss. I shortly touched this problem in previous slides, but here it will be more detailed. For the onset and development of pregnancy, it is extremely important that the mother's body accept the embryo. Usually, when we encounter the foreign proteins, such as bacteria or viruses, our immune system starts an attack. But what's strange is that an embryo is an organism that consists of the foreign proteins, and it is still accepted by the mother immune system. This phenomenon is called the immunologic secret of pregnancy. If this unique immunologic adaptation goes wrong before implantation, it will present itself as infertility. If it happens later, it will often present itself as a miscarriage. On this slide, you can also see the structure of the placenta, but it also shows how many different immunocompetent cells are located around the chorion. It is the balance between immune aggression and immune stabilization that is important for the development of pregnancy. After hatching, embryo directs its placenta into the prepared endometrium. Placenta cells produce proteins. This regulates lymphocytes in endometrium, natural killer cells, cytotoxic lymphocytes, regulatory T cells. Natural killer cells and cytotoxic lymphocytes melt endometrial tissue to pave the way for placenta penetration. T regulatory cells recognize embryo's proteins as own or foreign. If T regulatory cells recognize embryo as own, number of Treg cells goes up and they turn off natural killers and cytotoxic lymphocyte aggression at the right time to prevent embryo rejection. If T regulatory cells recognize embryo as a foreign, number of T regulatory cells goes down. It's not turned off and the embryo rejection. After proper recognition, cytokines and growth factors start being produced by white blood cells. The most significant cytokines are Th1 and Th2. The Th2 cytokines promote the growth of penetration of trophoblast as well as the formation of the new vessels. Th1 cytokines destroy placenta cells and activate formation of blood clots. Activate implantation is possible only under condition of a balance of Th1, Th2 cytokines. This reason may be different, but the rejection mechanism is the same. A decrease in the number of T-regulatory endometrial cells ultimately leads to the activation of natural killer cells and cytotoxic lymphocytes with predominance of Th1 over Th2 activity. Depending on the severity of immunological rejection, there may be first, complete destruction of the trophoblast at the early stage of implantation without any evidence that this implantation attempt was made will not be determined by HCG. Or second, partial damage to the trophoblast, which can be compensated, pregnancy will develop, or leads to a death of the trophoblast at a later stage of pregnancy. It means miscarriage. And how can we change the situation? First, transfer only one embryo. Each embryo has its own immune status. The reaction might be weaker in one embryo and stronger in another. When two embryos are transferred, the immune system will respond to the aggressive embryo and start the rejection process, but both of them will suffer. Glucocorticoids suppress all stages of immune response, and those will reduce the tight struggle between the immune system and the embryo, so that pregnancy will progress. Intralipid is solution of phospholipids. It suppresses natural killer cells for 2 weeks after a single infusion, which normalizes the balance of Th1 and Th2 lymphocytes. The introduction of immunoglobulins is advisable for chronic recurrent bacterial and viral infection. Low molecular weight heparins reduce the risk of microthrombosis in the immune rejection zone. The formation of blood clots is a separate mechanism for terminating a pregnancy, but it can be triggered by an immune reaction. This method has an importance in case with antiphospholipid syndrome. Granulocyte colony-stimulating factor treatment increased the number of decidual T-regulatory cells and vascular endothelial growth factors in trophoblast. This finding may explain the effectiveness of this treatment in recurrent pregnancy losses, probably regulating the maternal immune response through T-regulatory recruitment and the decidua, as well as stimulating trophoblast growth. So, now I would like to tell you about uterine reasons of pregnancy losses. We will take an whole group of disease. And let's start with the implantation window shift. The implantation window is defined as that period when the uterus is receptive for implantation on the 3-line blastocyst. This period of receptivity is short, around 48-60 hours, and results from the programmed sequence of the action of estrogen and progesterone of the endometrium. In the majority of women, the implantation window takes place around day 6 of progesterone supplementation. However, in 20–30% of women, the implantation window may be earlier or later than that, and we wish to investigate this in patients who come to us after multiple unsuccessful attempts. For determining this, we can now use the error test, which is based on analysis of 236 genes involved in the endometrial receptivity express themselves. This test is highly sensitive and specific. The error test is known for a long time. Here you can see the result of the error test performed in 20,000 patients. In 71% of cases, the endometrium is described as receptive. In almost 29% of patients, it is non-receptive. This means that these women have a shift in their implantation window. And in 85% of women with the implantation window shift, embryo transfer should be performed later than usual. Let's see how the error test is performed. In the cycle before the embryo transfer, we prepare endometrium. At the exact time, we prepare endometrium just like in the transfer cycle. For research, we take a small fragment of endometrium at the exact time when we plan to make a transfer. After 2 weeks, we will get an answer and find out whether the endometrium is receptive or not and whether the standard time is suitable for embryo transfer. Besides the implantation window shifting to the late or earlier, there might also be because whether the amount of time during which endometrium is receptive is shorter than usual. Here is the result of their test of several women. In the first case, the endometrium is receptive with a wide implantation window. The rest of samples show a window shift. For a successful embryo transfer, now we have information about how long we should use progesterone until embryo transfer. Thus, taking into account the results of the error test, we can perform a personalized embryo transfer and achieve our goal even in cases with repeated failure implantation. Other cases that can lead to pregnancy loss include adenomyosis, endometrial polyp, scar tissue in a uterine cavity, and endometritis. All these conditions relate in one way or another, changing the receptivity of the endometrium and leading to implantation failure. Quite widely, in our clinic, we use hysteroscopy to diagnose and treat intrauterine diseases. Hysteroscopy is an inspection of the uterine cavity under magnification using a camera. During the same procedure, with special tools, we can eliminate almost all the problems we see and prepare the uterus for embryo transfer. In addition, during hysteroscopy, we take a small fragment of the endometrium for additional analysis, such as histological, immunohistochemical, and microbiota ones, and of course, the ERA test. Over the course of 2 years, from 2017 to 2019, our doctors performed 433 hysteroscopies. We have analyzed each sample and gathered this valuable data. For example, this diagram shows the distribution of patients by their diagnosis, and you can see that endometrial polyps and the cervical polyps are the most frequent ones. As for the endometrial polyp, in my opinion, the situation is clear. Like in this photo, the polyp interferes with the embryo implantation and must be removed before transfer. Fortunately, an endometrium polyp is almost always visible on an ultrasound scan. But such problems as endometritis, sometimes adenomyosis, polyp of cervical channel, and abnormality of the uterus cannot always be detected, but only by making an ultrasound. According to our data, 44% of our patients with post-pregnancy losses and changes in the uterine cavity which were detected by hysteroscopy did not have any signs of problems on the ultrasound scan. To talk about pathology, first I would like to show you how the endometrium and uterine cavity looks within the norm. Take a look. The endometrium is evenly colored and is pale pink. A uterine cavity is triangle and sufficient volume. And this video shows a completely different situation. The patient was always told that her endometrium was growing great, even faster than in others. And for us, this is a warning sign. Why does the endometrium look thicker on the ultrasound than the doctor expected? Might this be signs of swelling and therefore inflammation? And right. Look how the endometrium looks with hysteroscopy. Many small polyps, like papillomas on the skin, a small blood vessels goes into each little polyp. This is a clear picture of chronic inflammation, which very often is a combination of bacteria and viral nature. Here is a picture of adenomyosis, a condition where endometrial tissue grows into the uterine muscles. Look at how many brown spots in the endometrium. They are dilated blood vessels. This is a woman with multiple implantation failures. In her case, adenomyosis was not in an advanced stage and was not visible in ultrasound. Also, usually it is enough. I would also like to show what adenomyosis is. You see the tissue, similar to endometrium, forms the cyst inside the muscles. Implantation failure in patients with adenomyosis can occur for several reasons, such as the unusual peristaltic activity of the uterus, impaired endometrial receptivity, alteration in the embryo-endometrial crosstalk, and significant negative changes in endometrium cells. One of the most serious pathologies in the uterine cavity is Asherman syndrome, when the synechia forms within the cavity. Fortunately, this problem is very rare. Just in 8% of our patients. In this video, we see a rather simple situation with single severities of fibrous tissue from the front wall to the back. With this, we can already plan an embryo transfer in the next cycle. In this video, on the first sign, everything looks good, and only the volume of the uterus seems to be reduced. But let's take a closer look, and we will see the real picture. We move the camera here and see that it is all synechia. And here too. It might seem like the mouth of fallopian tube, but look, this is it. The uterine cavity looks like a maze. And now, the picture after the dissection of synechia. The volume of uterus is fully restored, but we still need another 2-3 months to restore the endometrium and prepare it for embryo transfer. After hysteroscopy, removing polyps of scar tissue and scratching after hormonal immune and blood thinning therapy, it will be much easier for the embryo to attach. And I think you noted that quite often I said, on the first time everything looks good, but when we try to find the reason, we will be able to find it, and we can look at your medical history and situation under the microscope as well, and I'm sure that in most cases we can help to solve it. We offer you personal Skype with our doctor. We analyze your past fertility history and past attempts. We go into detail to understand what methods and treatments you react better to. We estimate the number of potential on-X IVF attempts to a baby based on your individual parameters. We offer a guarantee package with on-X if live birth achieved within 3 or 4 IVF attempts. If number of attempts with on-X is estimated to be too many and unrealistic, we open the door to alternatives such as egg donation. For Skype consultation with our doctors, we ask you to prepare the questionnaire, ultrasound examination result, journals about tests and treatments done before, and AMH if considering IVF with on-X. Our wonderful coordinator will help you collect data and prepare for your Skype consultation. And for me, every woman is unique, like a musical instrument created by a skillful master. My sincere desire is to tune an instrument so well that it will play an amazing, pure, harmonious melody of 2 hearts of a mother and her baby. Thank you so much for listening, and I'm ready to answer all of your questions via email tomorrow. You can send it in our number here on the slide. On your screen you can see it via WhatsApp. Tomorrow I will answer you. So thank you so much and have a nice evening. Take care. Bye.